Good evening, everyone. I am excited to introduce our guest speaker this evening, Stephanie Downs-Canner. She's the Assistant Professor of Surgery of the University of North Carolina, Chapel Hill, and is a member of the Lineberger Comprehensive Cancer Center. She completed fellowship training in breast surgical oncology at Memorial Sloan Kettering Cancer Center, and prior to that, she completed general surgery residency at the University of Pittsburgh Medical Center, where she was awarded the Doris B. Maxwell Prize for Excellence in her research for work on tumor immunology during the National Institute of Health's T32 postdoctoral fellowship in the biotherapy of cancer. She graduated as a member of the Alpha Omega Alpha from the University of Pittsburgh School of Medicine, cum laude. She has an undergraduate degree in economics and political science from Williams College, where she was a varsity lacrosse player. At UNC, she focuses her clinical practice on the surgical care of patients with breast cancer, with a particular focus on women diagnosed at a young age. She also runs an immunology research lab focused on improving immunotherapies for triple-negative breast cancer. And with that, I will hand it over to our speaker.
Thanks, Erica, for that very nice introduction. Can you see everything okay, Erica? All right, so tonight we're going to be talking about sex and fertility in young survivors. And I know this is a very sensitive topic, so feel free to take breaks, listen at your leisure. So breast cancer in young women is becoming more and more common. In 2020, 20,000 women under the age of 40 were diagnosed with breast cancer. And this graph here that we're looking at basically shows that the incidence of breast cancer in young women is going up over time, which you can tell because the slope of the curves here of all types of breast cancer and invasive breast cancer are heading upward. So there are particular issues that affect all cancer patients, but some that seem to be a little bit more important for our younger patients. And so we're going to talk about two of those today. The first is fertility. So what is fertility? That's the ability to conceive or become pregnant. And this ability goes down with age. The optimal fertile period in most women is between age 20 to 30, and then it goes down as we get older and starts to end after age 40. It's a little bit different for everyone. It's an important reminder that not having a period does not mean you are infertile. Contraception is really important, especially during treatment. Sometimes women's periods will stop during treatment, but that doesn't mean that you necessarily aren't ovulating and you could potentially become pregnant during treatment. So that's a little disclaimer. So why does cancer treatment change fertility? So chemotherapy causes the follicles in our ovaries to decrease in number. And it can also cause our ovaries to fail earlier, meaning we go into menopause at an earlier age than we would if we didn't take chemotherapy. And this depends on a lot of different factors, including the age when we're treated with chemotherapy, the specific chemotherapy drugs that are used, and then other factors like smoking, obesity, and if there's a history in the family of infertility. And it's really impossible to predict whether or not treatment for breast cancer will potentially make you have problems with fertility. Anti-HER2 therapies like Herceptin and Perjeta do not impact fertility. It's really the chemotherapy drugs that do, and tamoxifen and aromatase inhibitors that are medicines used in estrogen-sensitive cancers do not directly impact fertility, but they do delay the ability to become pregnant since people need to take them for a certain number of years. So how can fertility be preserved during cancer treatment? So one way is to freeze or cryopreserve eggs or oocytes or embryos, which are basically fertilized eggs, to be used at a later time after treatment is over. And then another thing that we can do is suppress or turn off the ovaries with medication during chemotherapy, which kind of lets them, in a way, go to sleep so that when we stop giving that medication and they wake up, they're more likely to work. So can people get pregnant after breast cancer treatment? We know that this doesn't have an adverse effect on cancer outcomes, but generally we recommend waiting at least 1 year to allow any damaged eggs that could have had damage from chemotherapy, for example, to clear. And that we prefer people to wait about 2 or 3 years after finishing treatment to become pregnant. And potentially outcomes could be worse if people become pregnant within 6 months of finishing treatment. And there's currently a clinical trial looking at when it's safe to stop endocrine therapy, which is medicine like tamoxifen or aromatase inhibitors, which are generally prescribed for 5 or 10 years. We're trying to see if we can take a break from those medications to allow women to become pregnant and then go back on the medication to finish out their treatment. When people become pregnant after breast cancer treatment, there's no increase in abnormalities in the babies. And for women who have BRCA1 or 2 mutation, there's the possibility of pre-implantation genetic diagnosis, which means if you've saved embryos or eggs, you could check and see if those embryos or eggs have that same mutation and selectively choose to implant or become pregnant with ones that don't have BRCA1 or 2. And breastfeeding is also definitely possible from one breast after cancer treatment. And then for people who cannot become pregnant, there's other ways to grow your family. There's surrogacy. You can also use donor eggs or embryos, and of course, adoption. So that's all I wanted to talk about fertility, and then I think we'll spend the rest of the time talking about sexual dysfunction. So what is female sexual dysfunction? We've all heard a ton about male sexual dysfunction and lots of commercials on television. But I've listed all the things here that can be considered female sexual dysfunction and underline the ones that may happen to women who've undergone treatment for breast cancer. These include shortening of the vagina and decreased elasticity or ability for it to stretch, or narrowing of the vagina. And then physical changes like fatigue, pain with sex, dryness, infertility, bleeding after sex, negative body image, loss of femininity, a change in response, decreased frequency of sex, or lack of sexual pleasure or satisfaction. And so if you're experiencing any of these symptoms, you are not alone. 40 to 100% of patients who are being treated for cancer report some symptoms of sexual dysfunction. So why does this happen to patients being treated for breast cancer? There's so many reasons. Many times a woman has to lose one or both breasts. There may be hair loss, change in body image, there may be weight gain associated with treatment, there are side effects of medication, there's stress, there may be premature menopause, changes to your body like lymphedema. So all of these things that are sometimes a result of being treated for cancer can result in sexual dysfunction. And we really don't talk about this enough. In one study, only about a third of female breast cancer survivors receive counseling on sexual dysfunction compared to 80% of male prostate cancer survivors. And specifically after breast cancer, many women report sexual dysfunction. In an average of 7 years after being diagnosed, about 2/3 of women reported sexual dysfunction. And the most common symptoms were vaginal pain, vaginal dryness, and loss of libido or desire. And most women prefer their doctor to talk to them about sexual concerns and bring this topic up with them, but we're still getting good at bringing up this sensitive topic. So how can we treat symptoms of sexual dysfunction? So first we're going to talk about vaginal dryness, which is a really common symptom related especially to aromatase inhibitors, but also to chemotherapy. And there's 3 main ways: moisturize, avoiding irritants, and lubrication. So moisturization, you want to make this part of your daily routine, especially for people on aromatase inhibitors or premature menopause or anyone having trouble with vaginal dryness. And this is done externally to the vulva. The most simple way to do this is with organic single ingredient coconut oil, which many of us have in our pantries, or hyaluronic acid products. I put a couple of examples of products here. And then replens or other polycarbophil products. What you really want to make sure is that you avoid any additives, fragrances, or dyes, and sort of gimmicky things like douches, which are sometimes described as feminine wash. And you'd want to check, but most of these moisturizations are safe to use with condoms. And then there's also internal, moisturizers like vitamin E and hyaluronic acid suppositories, but those tend to be a little bit messy. So some people don't like them because you have to insert them and sort of then like run to your bed and lay down, or they all fall out and get everywhere. So avoiding irritants is another really important thing to do if you have vaginal dryness. So if you would not put it on your eyes, do not put it in your vulva or in your vagina. So you want to avoid any fragrances and dyes and gimmicks. So be aware of fragrances and dyes and all sorts of things. Like bubble baths are really relaxing, but they're not really great for the vulva and vagina. Soaps, detergents, even toilet paper, pads. And another thing you can do is give the vagina and vulva some airtime. So sleep without underwear. And not always have something tight in that area, which will help. And then finally, you want to consider lubrication for any sexual activity every single time. There's a couple of different types, water-based. There's a couple of examples here. Good Clean Love and Blossom Organics have some. They don't tend to irritate, and it doesn't stain things. And then silicone type lubrication is long lasting, but does stain. And then there's hybrids, and then oil-based. Oil-based are hard to clean up and can impair the function of condoms. And then there's a list of things to avoid that may cause even further irritation of an already dry vagina or vulva. Glycerin, petroleum, propylene glycol. You can read them and make note of them if you're shopping for products. So what about vaginal estrogen? So this is a pretty complicated topic and can be used in some select cases of women who are having severe vaginal dryness after breast cancer treatment, but it's typically obviously not the first choice. And I will say it has been proven that it doesn't increase the chance of recurrence, even in women who've had breast cancer, but you would definitely need to talk with your oncologist before starting this, and is probably sort of used as a last resort for now. So what about dyspareunia? This is the medical word for pain with sex, and it can be caused by STDs, atrophy of the vagina, or vaginal dryness. So we've already talked about vaginal dryness at length. We've talked about moisturizing, using lubrication, and avoiding irritants, but what about these other things? So there's this funny little cartoon here you can read. He doesn't understand that I need to be preheated, so warm up. Women who are having a lot of pain with sex may need a prolonged warm-up time. Topical lidocaine may help, and you may need referral to a specialist. So be wary of surgical cures or gimmicks again. So lasers may really not be the solution and are not always done by people who are really familiar with the female anatomy. So be wary of that. Or things like vaginal steaming or jade eggs, be really wary of those. So topical lidocaine is not the first step. Generally, if you're thinking of this, you'd probably want to see a specialist in urogynecology because it could be a bladder problem actually, or vaginal atrophy that's causing the pain. But if those things are ruled out, studies show that topical lidocaine can decrease pain with intercourse, but can affect the partner. So generally we say to apply it to the external vulva, and the posterior fourchette is the most common area where pain is. So you can see there's a picture here of the vulva, and the posterior fourchette is sort of the back of the vagina. And so you would apply it to that area, wait 10 minutes, and then wash it off so it doesn't affect your partner. And it's generally given in a prescription form. Another thing that can be really helpful are things like this particular product called the O-Nut. This is just one example, but these are products that are sort of like soft rings that can prevent your partner from penetrating too deeply. And they're not painful, and they're easy to use, and you can change the number of rings you use depending on the depth of penetration that's comfortable. And then sometimes pelvic floor physical therapy can really help. So they provide really good education, and they can do manual therapy, biofeedback. And for some people that have vaginal atrophy, dilators can be really helpful. This is a picture of dilators here. And for women who have not been sexually active prior to treatment, it may make sense to consider a proactive referral to a pelvic floor physical therapist before becoming sexually active. Because if you have vaginal atrophy, it may be really painful to start becoming sexually active. So what about decreased libido? That's desire for sexual activity, and that can be related to anatomy, medications, and our partners. So it is not just dryness, it's a change in the architecture of the vagina, which we kind of touched on with the painful sex and vaginal dryness, but generally we recommend conservative regimens followed by androgens and potentially vaginal estrogens, but this definitely needs to be done under supervision of an oncologist and probably a specialist gynecologist who's comfortable prescribing these medications in women who have a history of breast cancer. So a lot of medications that we use to treat breast cancer can also cause decreased libido. Aromatase inhibitors cause decreased libido in about half of women. Also, women on aromatase inhibitors report insufficient lubrication and pain with sex, which we've already kind of talked about, troubleshooting tips for that. And then tamoxifen can also cause pain with sex. If libido is an issue, you could potentially talk to your oncologist about switching to tamoxifen from an aromatase inhibitor if conservative measures fail. But again, that's something that you need to talk about the risks and benefits of with your oncologist. And also, medications for anxiety and depression can negatively impact libido. So SSRIs, selective serotonin reuptake inhibitors, are some of the most common medications we use to treat depression and anxiety. And up to 80% of patients on these have some sort of sexual dysfunction, including decreased libido and difficulty with orgasm. There is one medication that's used to treat anxiety and depression, which is called Wellbutrin, which does not have the side effect of sexual dysfunction. So other options would be to consider a sex therapist. I put this picture here because there's people who are actually qualified and trained to do this. And so the American Association of Sexuality Educators, Counselors, and Therapists, or ASECT, has a website, and you can look up for certified therapists in your area. And then finally, we should include our partners in this. Sometimes people may need counseling, may need to have some date night, keep open communication with their partner, and not forget that STDs can contribute to decreased libido and other things like pain with sex. There is no female Viagra. We all know plenty about male Viagra from all of the commercials. There are a couple of medications that are FDA approved. One is filbanserin, which is a serotonin modulator, and it has some FDA regulations, and it's a medication that's taken once per day. And then there's Vyleesi, which is a different type of medication, but it is an injection, and most women are not really up for injecting themselves before sexual activity with something that needs to be injected by needle. And then Ristela, which I don't think is approved yet in the US, is a plant-based supplement, which may be promising. So that is all I wanted to cover, but I did want to provide a lot of resources. So there's tons that you can learn about. There's a great Instagram called @music_sex-after-cancer. This is an Instagram of an OB-GYN who is also a breast cancer surgeon and has a special interest in sexual health after cancer, and she provides a lot of great pearls there. A urogynecologist might be a great place to start if you're having symptoms of pain with sex or severe vaginal dryness. For mild vaginal dryness, you could just try treating at home with avoiding irritants and some daily moisturization and lubrication with sexual activity. And then ASECT is a great resource for sexual therapists. There are a couple of good podcasts, Sex with Emily and Sex Gets Real. There's a great YouTube tutorial put on by the Sylvester Comprehensive Cancer Center, which is in Miami. It's called Sex After Cancer, a virtual workshop for women, and it is available in English and Spanish. And then I put the number to the UNC Chapel Hill pelvic floor physical therapists, who are wonderful, 984-215-4970. They have locations in Durham and Chapel Hill, but I'm sure there are others. And then I did want to mention that fertility preservation can be really quite expensive. And there are a couple of organizations that offer financial assistance for this. including Live Strong Fertility and Heartbeat. And I've just listed the names here on the screen so you can see them. And I just wanted to thank my colleague, Dr. Rojas, who has the Music Sex After Cancer Instagram site, as well as all of my patients, for teaching me about what they've gone through and helping me educate others. Thank you.
Well, on behalf of Susan G. Komen, we would just like to thank you for sharing your knowledge this evening. And we hope that this has been helpful for everyone who gets to watch it.